to welcome everybody to Grand Rounds on this rainy Wednesday morning. It's a nice way for all of us to get together, and for me, it's exciting because Rob from University of Washington, that Tom will introduce, we are related somehow, but we haven't quite figured out how, because his grandmother's last name is Stoller also, and apparently we look quite alike. So it's nice to have family here. So nice to have everybody here. Tom, take it over.
Well, it's a real delight to have Rob Sweet from the University of Washington join us for Grand Rounds today. For people that don't know him, he's the medical director of the University of Washington Medicine Kidney Stone Center in Northwest Hospital and the executive director for the WWAMI Institute for Simulation in Healthcare and executive director for the Research and Education Simulation Technologies. The list goes on and on of all the stuff he does, but most importantly, he is an unbelievable innovator and collaborator and brings creativity to everything that he does. He's got a huge, amazing lab that's DoD funded and focuses on simulation. I was lucky enough to actually go there and visit him a couple of years ago, of course, pre-pandemic. And it's the only lab I've ever been to where somebody has hired a Hollywood makeup artist. So hopefully we're going to learn more about that in his wonderful presentation today. So thank you so much for being with us today, Rob.
Thanks, Tom. And it was such a joy to have you. And thank you for teaching UW faculty how to do ultrasound perks. That was a wonderful visit. Thank you for doing that. It's a great honor to be here. Your wonderful institution. I had the pleasure of being a sub-I there, as many of us have, and enjoyed it then. And we have such a strong relationship between UW and UCSF. Many exchanges of many talented folks have gone back and forth between our institutions, and it's a wonderful collaboration we continue to have. So thank you for the opportunity to do this. I haven't done this before, a virtual Grand Round, so we'll see how this goes. I'll go ahead and share a screen here. Hopefully everybody can see that. Are we good?
Looks good, Rob.
Wonderful. Well, I entitled this Coming Full Circle, and for simulation for open surgical applications. And I do have a couple of disclosures, but the Boston Scientific one really isn't relevant at all. But I did start a spinoff company with simulation products. It's the only way that we can get these things into the hands of folks is to be able to have a mechanism to do that. And there's only one thing that I'm mentioning here that has any relationship to that. I'll highlight that. It has nothing to do with urology, though. So as far as the stat, why am I doing this? Why are we talking about this? When we think of simulation classically, what we've done, and Marshall and I were just talking about this, almost all of what we've been doing and developing have been in the endo-lab robotic space. And it's really grown over the last decade. It's been well adopted by many courses and programs. However, with that comes a decline in the number of open surgical cases for our trainees. And there is a concern, and there's now been more and more papers out there with voicing that concern. Will our trainees have the ability to do open surgery if they need to, especially if they get themselves out of trouble? We don't know the answer to that, but so there needs to be a shift in our training paradigms and approaches to potentially improving and offering opportunities to develop open operative skills, maybe outside of our classic operating room experience. So many places have labs that have simulation options for open surgical skills. Animal models are common for really complex things. Some live animal labs still exist, though they are decreasing over time, both from pressure from interest groups that are pressuring a lot of the institutions to try and move away from live tissues, cost, complexity of these type of models as well, and availability of them seems to be becoming limited more and more. A lot of the programs do rely on butcher models and still do. That's a common way to address these skills. So I'm going to show you coming up here, there's a lot of things that are different about them that we really haven't studied before that we need to continue to study to understand the important differences between some of these models and human tissues. Fruits and vegetables are commonly used for some basic skills and can be used, like sewing the skin of the grape and other things like that, or oranges and other vegetables for maneuvering. Certainly readily available and easy to use, low cost. Partial task trainers like the ones you see here, and then human cadaveric models are also good options for certain skills, but again, limited availability. So what's out there right now as far as open, like synthetic type simulation systems? One out of San Diego is the Strategic Operations Cutsuit. It was actually developed by a Hollywood producer type that does a lot of films and does trainings for the military. It's basically a suit that a human can wear, and you can do certain procedures, for example, in the field with a talking person. We actually adopted part of this when we did our Combat Casualty Training Consortium project. We used the chest for chest type procedures. Pretty high fidelity with some of their models, but it's not connected at all to physiology, and the parts are quite costly to exchange. There was one right before I changed this, because Operative Experience had one. It was connected to physiology, but I was going online. It's gone. I don't know what happened, if they just took it off the market or what, but that was the other one. And you can do brain surgery. You can see here fasciotomy as another option here, but you used to be able to do laparotomy, and I don't see that you can do that anymore. So what are we talking about here? And when we go back to our engineering team and we talk about what are we trying to do, and we always want to define that, is develop something that's acceptable with low cost and high usability around a construct. In this case, so everything that we do in the studies we want to study based on this to show that it has validity for what we're trying to do, either training or assessment. The purpose is preparing our urology surgical workforce to manage diseases of the abdomen and pelvis, in this case, with open techniques. So the engineers say that's not enough. I want specific requirements. Well, we're talking about accurate anatomy and tissue fidelity. We would like to have multiple pathologic options, obviously. From a cost standpoint and ease of use, making each of the components replaceable, but minimize only those things that are replaceable that were damaged. You don't want to have to spend a lot of money replacing a lot of different organs if you're not going to be interacting with them. Being able to maybe 3D print them right there on site would be nice. And we're working on a DoD project that I'm not going to talk a lot about today, but we're able to directly print soft tissues. Replicate things like blood, urine, succus, and also connect to physiology so that we can even do team training with anesthesia and our nursing staff around critical events as they relate to what we're doing in the abdomen or pelvis. And then automated performance feedback. So it's really nice with simulation is you can embed sensors. And I'll show you an example, Carla Pugh's down at Stanford, where we can give automatic feedback to the user right after they're done and help form their learning experience, and they learn right away. And that's the most effective time to learn, is right after you've done something. So providing that guidance automatically is great. So this slide just sort of highlights the types of work my lab, the Center for Research and Education Simulation Technologies, does. We do multi-institutional validation trials, looking and evaluating simulators. We do a lot of simulator development. We actually started in the virtual world, and we've gone more into the physical with sensor type world, but we've also done hybrids that have both VR and physical components. We have a human tissue property database, which I'll talk a lot about here today. And then we do some procedural human factors research as well. So one of the important things as we look at this, because I mentioned fidelity, and for open surgery, unless you want to just teach R1s, you have to have fidelity and improve it, because otherwise it just loses its value as you move along in your surgical timeline and development. It's just not going to be applicable for someone who practices a lot of surgery unless you improve the fidelity to the point where it looks like, feels like, behaves like at least those three. And so when we talk about fidelity and simulation, you look at the literature, unfortunately, there was a lot of confusion. People sort of use the word fidelity to mean, oh, if it uses a computer, it's high fidelity. And it's just not true. Or they say, oh, if it costs a lot, then it's high fidelity. Well, that's not true either. Fidelity is simply the likeness of something to what you're intending it to be. In this case, a human organ or a procedure on a human. That's what fidelity is. And so we've divided it up into these things. What does it look like? So that's the geometry, anatomy, the optical fidelity, the colors and textures and reflection. And in surgery, feels like in open surgery, open surgical techniques, this is really important. The texture, the friction, the weight, the wetness, and then also how it behaves. The physiologic response, the actual mechanical response. When you interact with the tissue, does it move? Does it deform? Does it cut appropriately? And if it collides with another organ, are there organ deformations? Especially important in the VR. And that's why a lot of the VR hasn't taken off for us. It's not realistic the way the tissues interact and the organs interact with each other. So over the last decade, we've been working on developing and defining tissue characterization. And so we've had tissues come to us through a relationship with our tissue procurement group. We do uniaxial and sometimes biaxial testing, indentation. We used to do some thermal conductivity. We don't do much of that right now, but looking at their optical properties and dielectric properties and conductivity, and looking at them and then building analogs, synthetic analogs that match those properties. It's very valuable information. In fact, I would argue if we ever want to get into really using AI for surgical devices, you got to have this, because otherwise it's garbage in, garbage out. But if you have the data on the tissue, the model that we're interacting with, or our future surgical instruments that are going to be interacting with, you have to have this data. There's no way around it. And this then leads to all these other things, which I mentioned, rapid device prototyping, patient-specific planning. It really opens up what we're going to be doing in the future. We think it's an important project. Example of some of the classic tests that our biomedical engineering colleagues sort of helped us develop, and looking at biaxial and in this case uniaxial testing. Here's a skin, for example, and looking at, in this case, a pull to failure. Other classic tests are looking at Young's modulus or stress strain ratios, and things like that. Failure modes, when can we make it fail, or pull to failure, and stretch ratios. Those are all things that are the classic things that they do with tissues. But we did that for a while, and we realized we made materials and they still didn't seem right. Even though they matched Young's modulus, they didn't seem right just to the eye or to the feel. And so we started to move away from these general to task-specific apparatuses. And so we built, this is called Dexter, and this one here is called Bernie, the little blue one, because we're doing burn tissue with them. These little robotic arms, we didn't build Bernie, but we did build Dexter. And looking specifically at instrumenting them with instruments that we use in the OR, and then interacting specifically with the tissues that we would normally interact with: puncture, palpation, dissection, cutting, suturing, incising, and friction. So those are all the types of things we do commonly during open surgery, and we have to characterize those with the tissues we're interacting with, and that's been where we've shifted over the last 3 years. Here's one example. Our current now chief resident, who's going to be a pediatric urologist. This is when she was a master's student with me at Minnesota. She was characterizing percutaneous puncture of the kidney, and she did her master's on this. And she actually developed Dexter, and she's seeing what all the forces are going through all the different layers to get to and puncture the collecting system. And then she developed the material, which you can see here in the blue, which matches the green data that she had from her puncture. Now, what this light blue is what they were using before as a material as a single material synthetic model. Looks nothing like, or feels nothing like, what you would actually insert a needle into the kidney. So this is the type of work that needs to be done in order to increase that fidelity. So we've been publishing on different, again, properties such as, in this case, pancreatic duct anastomosis during a Whipple. We're doing suture pullout forces. Here we published in biomechanics. There's a lot of interest in surgical airway and puncturing the cricothyroid membrane. We published on that here in Journal of Biomedical Engineering, again, using that and using a scalpel on the end of that machine. And here's more of a blunt puncture of some connective tissue. We're really interested in connective tissues because that's where we operate most of the time, not the organs themselves. And so characterizing connective tissues is one of our focus. So what's really interesting is we started now shifting, because you'd argue, okay, well, you take these, tissues out of the body, even if they're within hours of death, which we do. We don't want to leave them and wait for a really long time, because rigor mortis and the tissues are stiffer and they don't behave quite as accurately, even with storage solutions that we use, is going in situ. And I say in situ and ultimately potentially in vivo, because those tissues are actually in the body when we're testing them rather than taking them out. And that's important too, because of how they're related to surrounding structures. So Dr. Kovlevsky, one of my partners at University of Minnesota and friends, colleagues, he's at mechanical engineering. We worked with him, developed this handheld probe where we can actually go in the body and do things like force, torque, and position if we're attached it to a microscribe. There's a 6-degree freedom load cell that and 2 USB cameras, and we're able to do all kinds of testing with scalpel, needle, and some other end effectors in the body with this device. Now, it's not sterile, but depending on the situation, I think this is kind of what we're going to be doing this year, and our simulation fellows are probably working a lot with this device in cadavers as they're procuring organs, et cetera. Right when they're done with that process in a donor, we'll be able to do and test these tissues, especially connective tissues in situ. So making a little shift here. So the other side of things is the digital side. And this is work we've done for a long time. Dan Brooks came from EA Sports originally and has worked with me since I think 2008 when we were at Minnesota. He came back with me to Washington as well. And works on it. He's a digital anatomist at this point, and he's worked on a lot of the models that you've seen us do in the past, including the green light simulator when we built that system. He did all the modeling for that in the digital world, and you can see how he goes from a rough model all the way to a real high fidelity model here with the kidney. Just gorgeous work, and it's important too to help speed our engineers. CAD designs as well as we take those from DICOM data sets. Another shift of gear here is an example of here's an undergrad capstone project. I'm really proud. He did a great job, Hans Eriksson, in developing a composite hydrogel rather than silicone small bowel anastomosis trainer, focused on simulating the opaqueness and the color. We used some silicone pigment, but it was a hydrogel. So you're able to suture it as well as able to use electric cautery, which is important as well. So we looked at surgical performance, looking at how our surgeons come evaluate it. It cut well. There was a blooming effect, not quite perfectly when you incise it in the mucosa, it everts. You were able to suture it and staple it as well. And we did several user tests on this material, and it performed very well. More importantly, I wanted to show you some of this data. When we actually took, you can see here in the green, and then our blue is our hydrogel. We call isotropic. Okay, so it's a material throughout with the same stretch both directions and same properties in both directions. Whereas most human tissues, what we call are anisotropic, or will have different properties if you pull it one way versus another, just the way the architecture is histologically. But if you look at it, is with human bowel for suture pullout, tensile strength, elastic modulus, and ultimate tensile strength, our hydrogel performed extremely well, if you see here, compared to human small bowel. Now I want to show you these. Now the pink graphs here are the industry standard right now. That's if you were to go out and buy small bowel to do this type of work with, that's the pink. And then the other interesting thing, here's the yellow graphs here are porcine. And then what you see here is just axial versus transverse. That's not as important. But the pink, again, industry, yellow is pig, green is human, and blue is our hydrogel. And if you go through all these, ultimate tensile strength, suture pullout force, again, blue is matching really nicely with the green. The industry is out of whack, as is the pig, frankly. So if you're using pig for suturing small bowel anastomosis, not a good model. Elastic modulus is ridiculously low in the industry model versus, again, human and our hydrogel are almost matching perfectly. Porcine's not too bad there. And then ultimate tensile strength, again, the industry, it's nothing like a human model. So these are the types of tests. Again, if we're going to look at this and try and increase the fidelity, I think it's important to have a model that actually matches what we're trying to do. This is some work from Dr. Carla Pugh at Stanford, and many of you may know Carla. She's an engineer and a general surgeon there. And what she did is it's called the Surgical Metrics Project. It's funded by the American College of Surgeons. And in this case, her question was why do bowel anastomoses leak? And she actually synced up, maybe some of you participated in this. There's a video capture actually measuring EEG and motion tracking in the hands and audio capture as well. And then looked specifically at why anastomosis leak. She took, in this case, pig bowel, unfortunately. She used that as the model, but she had 255 participants. And of those, 50 of them, that she had 2 injuries. She had a longer injury that was more obvious, but next to it was a smaller one that wasn't so obvious. And she went to conferences and had surgeons who were in practice, including some retired surgeons, do this. 50 of them actually missed the injury completely, the small one, not the big one. And so, most of them did see both of them, 156. But I want to show this pathway here. So if you follow this pathway down the red, that's not good. Okay, this is all these things and these steps showed a higher chance of a leak if you went down the red pathway versus going and doing what the other side was on this model. So if you connected the 2 injuries and you found them both, first of all, and then you sewed it together, you had a less of a leak rate, 4% versus 22% if you repaired both of them individually. Interesting information. If with the large injury, you did a double layer versus less of a leak, 5%, but if you only did a single layer, it was 28% leak amongst these folks. If you did interrupted, you had a 37% leak versus only 21% if it was running. And one of the more interesting ones is that whether or not you put a corner stitch in. So a corner stitch, 57% leak if you didn't put a corner stitch in, 12% leak if you did. So it's, we always sit there in grand rounds in M&M and we argue, interrupted versus doing running or the method of leak, et cetera. I mean, so this is a great way using simulators potentially to find out really the truth. What's going on here? Why are we having leaks and when maybe in other cases not, and help refine our technique. So other things, number of throws mattered and when she was looking at this, whereas if you used more, in this case 6, you had less leak. And then bimanual dexterity was also a factor as well. Again, switching gears a little bit here, going now to the physical side. These are some of the models. This is Jason Spike, and he is an artist, and there are artists in our group as well. We don't have that special effects artist anymore, Tom. We used to, but she's moved on to better paying jobs. But we do a lot on the physical side. These are just some examples during our laparotomy that we built. These are all synthetic models that we use for a laparotomy model. Here's a plate that includes the cave in the kidneys. Here's a ureteral trainee model. These are all replaceable. Some bowel here as well. So John Wingate was our simulation fellow. He was a trauma fellow at UW for a while. He's now an attending at Madigan and UW. He worked on a ureteral trauma trainer, which we now have a grant to work on. But before that, we were just working on it on the side. And then an insufflatable abdomen here. This is actually for robotics and laparoscopy, but I wanted to show it anyways. Dr. Rabley, who's our current endo fellow and is taking a job now in Utah next year. He was my simulation fellow the year before, and he developed this trainer to, again, it's an insufflatable abdomen. You can train various needle access with that particular model. So here's just some pictures from in action with our laparotomy system. In this case, a splenectomy. We had a cystoscopy as part of it and fixing that as well. One of the other things we wanted to focus on is being able to provide automatic feedback. We talked about that at the beginning. And one of the ways we're doing that is looking at mechanophores and chromophores and thermophores. So these are materials that change color based on either, in this case, mechanical stretch, or they can also change color based on heat, or they can, or pressure, or different things can activate color. And that can actually tell us things like where people are putting strain on tissue, which is important. And we use this concept to here with facial plastics. And we took a model of a face here, which to the naked eye looks just like a silicone model. And then they did a series of plastics procedures. But then when you shined a black light on them, you could actually see that here were the Langer lines here that were present within the model that you didn't see when you're doing the procedure. And you can see how an expert's lines line up versus a novice's. And so it really gives some information to the learner as to how they might improve their reconstructive or plastic techniques. It's really hard to explain sometimes if there's too much tension on one part or another. We can actually now quantify that with things like this. Here's another example. Again, on this face model we have here, we're applying heat to it. And I'm going to speed it up a little bit, but you can see how it changes color with time and changes into, different, you could represent different rashes or bruising or whatever you'd like to represent how tissue might look with a whole bunch of different colors. Here's another one, in this case, using visual light. We're just going to shine a light on this, and you can actually then, it automatically changes different colors. You can see how powerful that might be to increasing and creating visual cues during the simulation that may mimic what we're trying to mimic. Like, for example, ischemia. Here's one for infection that one of our, she did in the Capstone Senior project, one of our engineers, and she then did a master's program. And she developed this little wound, and then with increase in temperature to body temperature, up to a fever, it automatically turns red. And with that, it also swelled, as you can see here from the left to the right. It just shows, so there's swelling, there's erythema, and I don't know if you can appreciate it, but there's also pus. So the pus, here, I think this shows that too. With time here, as it heats up, and this red light that you see here is she's just measuring the temperature on the surface as she's going on and heating up the unit. So we can reproduce an infection dynamically in this model, and then you'll get pus. And then when the pus dries, it actually looks like a scab as well. So which brings us to a project we worked on that brings all of these things together, and it's called MOSES, not the Moses, Boston Scientific MOSES, but it's called the Modular Healthcare Simulation Education System. And it was a DoD project where they were looking for a platform where all these different simulation systems could potentially talk to each other. Think of it as a unifier, an integrator, which is of value to them because right now there's a lot of separate ecosystems. One person's system does not talk to the other. So if you have common standards and you develop a platform, a core that allows these different systems to talk to each other, you now have a modular ecosystem. And that's what we did and developed and finished. Allows for interoperability. It boosts our overall capabilities and applications. It's modality agnostic, so you can have virtual models talking to physical models and vice versa. It also allows some of these physical models that we're working on to connect to physiology, which gets really interesting because now we are actually dealing with an entire patient. And so we did this project, and it's all open source and available. So anyone here that's interested in doing simulation development, here's a digital data set that Dan Burke developed of the head to toe human male. We have female as well. all different organs. Each of these organs you can take separately if you need it. You need a lung, you need a kidney, you need a bladder. You can take that high model and it's free and it's available. You see it's connected here. We actually created a connector as well that's universal that allows for power, fluid, air, gas, all in a toolless connector. Again, one company can make a leg, one company can make a liver, one company can make a head, and they connect with each other and they all talk to each other. So it's a universal connector, and that design, again, available, open source and free. We also connected to an open source physiology engine called BioGears. So it's still developing different capabilities, but it has a lot of capabilities already. Again, a great thing for students to jump on, especially engineering students and medical students, to develop their own and use their own physiology engines and explore what might happen if you do this, that, or the other thing to the human body. Well, lots of capabilities. Again, BioGears is integrated, though it can work with other physiology engines. So in order to demonstrate that our system worked, we took one company's virtual patient, we connected it. They took Moses and were able to connect it to our IV module. And there was another company that had an abdominal exam simulator that worked. You just clicked it in and it talked to everybody else. Their CAE had an ultrasound fast exam simulator that also talked to everything. And we had our laparotomy module. We put them all together and you could easily, quickly swap them in and out in one patient, in one scenario, and deploy. Yes? Does someone had a question? No. And so this is kind of the way the data looks going across it. So you insert a module here, it knows what it is, and it talks to the physiology engine here. If you give drugs or fluids, physiology engine responds, talks to the virtual model. If you do something, for example, you have blood loss in the abdomen, physiology engine knows, anesthesia sees that. They have an airway simulator if they need to manage it, provide fluids or whatever. It goes back and forth seamlessly. Again, different companies don't even need to talk to each other on sharing each other's IP, which is important here if this is going to work. But through Moses, it resolves everything through the platform. And here's just an example. This is Ron Mayer, trauma surgeon. He was the president of the American College of Surgeons, working with our SIM fellows here, doing a laparotomy scenario with anesthesia and the laparotomy module specifically.
All right, I'm giving him living. I'm giving him a unit of blood, it's FFP.
Nice exposure of the vessels. Beautiful. Feel. The vessels are okay, it's not bleeding anymore.
So in this case, there was this splenic laceration, which was bleeding,
2 units wide open.
and they're doing a splenectomy.
The ABG, I'm getting an.
And now they found a bleeding vein, probably an iliac.
Let me know when you have it under control.
Okay. Right by the iliac.
Do I need to start a massive transfusion protocol?
Yeah, please.
Okay. I'm letting the blood bank down.
The interaction is really important here in training those things like closed loop feedback in scenarios where there's mass hemorrhage or something like malignant hyperthermia or anything where we may need to have a lot of communication back and forth.
Okay.
Great platform for that because it keeps the surgeon engaged
Okay.
and the anesthesiologist engaged.
But the bleeding is controlled.
It just came back. Hemoglobin 6.8, and he's getting 2 units of blood right now.
Okay. Bleeding is controlled right now. I'm gonna release the clamp in 30 seconds.
Okay. Gonna move along here a little bit. They move on to they recognize the bladder injury.
He dripped down a little bit.
Patient's doing better. They're sewing it. And then at the end, once they're done,
Look at that.
they can test it
Good.
for leak.
Pretty amazing. Good, good. No leak. Perfect.
So here's where we're developing it.
That is awesome.
Yeah, I just like this
Being a cave visitor
reaction
like
from
that.
Colonel Rush here.
Yeah, please like that though.
Second there.
So we just did some pre-pilots with this system, developing the laparotomy component of it. Closes up so you can see with the vena, in this case, you had a vena cava laceration and repair, doing this trauma cystography. But then what we did is put it in the hands of some of our colleagues, Dimitri Stefanidis at Indiana, Raj Agarwal, big names, Gordy Wisbach from San Diego, big names in the simulation world. Dr. Sachdeva, the director of education for the college, they took it and brought it and evaluated the system. And what they did is they compared our Moses platform to just taking the individual task trainers alone, and then looked at feedback and focus group, looked at usability and things like that. Basically, as far as demographics, we had first, the patient went all the way from the field to the ER to the OR, one patient all the way through, and in all the different phases, and did it seamlessly with just swapping out different modules, like the abdominal exam simulator, swap it out for the laparotomy, for example. So this is how that worked. First responder in the field went to the ED trauma bay, then the anesthesia and the anesthesiologist and surgeon evaluated the patient, and then they took the patient to the OR and actually did the operation together. Anesthesia thought it was okay. They didn't have a lot to do, and that's part of the way we developed the scenario, and that was on our bad. We really didn't make it that complex. They basically gave fluids and they gave, blood. But there's a lot of interaction back and forth. The surgeons loved it compared to the peripheral model. And in the end, what we also found is that it was really superior to the peripheral task trainers alone, for going across all these different phases. The strongest points were its perceived ability to enhance, again, that interprofessional team training that you saw happen during that pre-pilot that involved multiple specialties. It was highly rated characteristic for physiology. The monitoring equipment and feedback mechanism had a physiology engine, and it vastly improved the realism of the system. So we really show that it has a lot of value, and you can imagine for other areas in urology, especially if we're going into open surgery, how important a system like this will be to allow us to basically crowdsource open surgical simulation training. Another shift here, again, we want to make these available, and being able to make this reposable or disposable organs, maybe even print them yourselves. This is an example of we worked on a project with Minnesota, Mike McAlpine, where we printed directly, instead of through mold cast process, a prostate. And we took a patient's prostate, and we developed an ink that has the right properties. And we also embedded sensors and batteries and electronics that all imprinted directly into this prostate. This is how you print things like electronics, D part of this particular slide. You can see here how we wound up printing this, taking a patient-specific MRI, and then after radical prostatectomy also looked and compared it as well. So we were able to develop a model that looked like, felt like a prostate in this particular case, kind of as a proof of concept. So again, we characterized the properties, we developed the ink, we modified the ink based on histologic and the data from those properties. But then on the imaging side, again, using the patient's MRI, developed the CAD model, and then with histologic data, ultimately created a 3D print that you could just print that prostate. So we've focused on developing female models as well going forward. It was important. We didn't have a lot of female trauma models, and the militaries were noticing that female trauma was getting missed. And a lot of it was due to some of the sexual sensitivity training they were receiving. They were afraid to touch or move the breast, and some thoracic injuries were being missed. And so we developed a female trauma training system that does a lot of what the male trauma training systems do. And we developed an Asian one as well in this case. And this one actually is ready to go to market. And this is the one that's through this Imagine mechanism, this airway trainer that now our Medic One uses here for their training. And military wants to use it for their surgical and endoscopic airway training as well. We just got a grant from the Department of Defense. I mentioned Dr. Wingate's ureteral trauma simulator. We finally got that funded. We're working on that now. We define the suture pull-up force of the human ureter, and we're starting to develop all the models and the molds through the process I just showed you to move towards being able to train doing repair for those of us that are on call and don't do it that often, and for those that need to deploy and do it in the battlefield setting. So we're about 2 to 3 years, I would say, out from having a deployable, modular, kind of interoperable, open surgical simulation training system, at least in our lab, with integrated physiology. We've done a lot in this area. We have a lot of work still to do. And what that means is, and we've done this recently, is kind of treat simulation science as its own science and its own field. And the reason for that is it's multidisciplinary. You heard artists, engineers, clinicians, educators. That's our Venn diagram of skill sets and cultures and knowledge and background that lead to success in this field. So we created our own division, healthcare simulation science, and we have 4 faculty now I've hired, and we have 32 adjunct faculty that all contribute. We're proud to say we're going to be launching a master's program in healthcare simulation science. Hope to start, I think, this coming fall with our first master's students. But these are all the programs that lie within my division here, 3D printing program, and then WISH, which is our training center, CREST, which I just talked to you about, and then our master's program. And the other piece is our fellowship program. And so here, these are all fellows that date back to 2009 that are, a lot of these people you recognize are doing outstanding work in urology and in other fields in the area of simulation. And I'm probably the proudest of this particular accomplishment is getting this program started for the college, and then ultimately for both Minnesota and UW, and being able to work with these talented individuals who have a passion for this. And these are the folks that are taking this field forward, ultimately. They've done outstanding work, and we do this. It's a funded fellowship. It's accredited by the American College of Surgeons. It's endowed, and it's a great program. And that's it. Thank you so much for your attention. Appreciate it. I believe this is how you get your CME credit. So if you want to scan this QR code, you'll get credit for listening to me this morning. So thank you.
Well, that was just a phenomenal talk, Rob, and the videos and just the examples of what you can accomplish in a virtual environment are just amazing. While we're waiting for people to post questions, and please, folks, feel free to post questions in either the chat box or the Q&A. I had a question to kind of start from. So you mentioned that you probably are 2 or 3 years away in your lab from being able to kind of broadly allow people to have access to these types of modular, integrated systems. So I guess the questions I had was, one, what does it take to actually bring models like this to scale? So to be able to do, multiples as opposed to a single one-off.
Yeah.
And then 2, when you hit that point, where do you think these models would have the biggest impact, positive impact?
Those are great questions. There's multiple factors here. When you're trying to bring something like this to market, it's important to have a mechanism to do that, right? And that's one of the reasons we did this startup company, is to have a mechanism to be able to get them to people. I don't care if we make any money with it. I really want to make sure if we make these things and they sit in my lab and collect dust and they're great for presentations, what have we done? I mean, ultimately, it's important that they get into everyone's hands. That's what's important. And with silicone, it's pretty simple. It's easy to mass produce those, and that's been done for a while. You develop tooling and the manufacturing process. You make sure as you build it, and some of the models that we've built in the past that we make by hand, that is not the way to go. You're no way you're going to be able to deliver enough and on time. It's not a business model at all. You have to invest in the tooling to make multiples of these in a different way, using manufacturing processes rather than handmade processes. Hydrogels are also, as you saw, we're working with them, and they're great, especially for open surgery. We need them. But Dr. Ghazi, and I didn't mention him, he's doing awesome work. He was at Rochester, he's now at Hopkins. Those are fantastic models. You probably use those as well. Those are hydrogels, but we're finding the same thing. The process to make each one of those, it's very, it's each one's by hand, and it takes days, sometimes weeks to make each set of models. So finding a manufacturing process for hydrogels is going to be really important if we're going to continue to move this forward. Trust me, there are a lot of folks working on that right now. I'm thinking about that. Biggest impact, I do think it is open surgery. I mean, a lot of what I showed you today applies to endo lap as well, but I am concerned about our ability to maintain open surgical skills. It can't disappear. Those fundamentals are still important, and that experience is important. And we're all going to need to lean on those at some point.
Rob, are there other applications outside of medicine, like for avatars and for, you think about the Star Trek companion that comes to you? Is there an opportunity there for funding or to increase the number of these products that you make?
Yeah, absolutely. I mean, this field, as I mentioned, it's multidisciplinary. We talk about parts. So I encourage our faculty members that come with different backgrounds. They are our liaison to these worlds that you describe. Like the special effect artist or the sculptor, molder, the human factors person. We rely on them and their experience and their network of colleagues to tap into those worlds, so to speak. What funding? I can't say we've looked at it. We've never been successful in getting funding from a peripheral field for us, because I think they see us as like we have all the money and we get a lot more funding than the art department. They don't get much. They don't get as much funding, and so it's hard to make that argument. And they're doing art for art's sake, not necessarily for an application like we actually have a use for that. And so there's some challenges there when you're going into some of these other fields. Interestingly, one is computer science, because they do have money. And it's convincing them that we're novel enough and important enough to apply their talents and skills to our field. And by having a division, I think that helps that a lot, because now we have an academic unit. It gives us some academic prowess, so to speak.
David is a great.
Yeah, I'm sorry.
Okay.
Go ahead, Al.
I was just going to say that simulation is clearly a closed community. He's on the webinar, and to thank you for the shout out and appreciate your work.
Oh, you bet.
And then there's a couple of questions in the chat. So one of our residents, Dominique Escobar, also says, awesome talk. How do you translate information about force needed to damage tissues into terms trainees can understand?
Yeah. And I think one of the ways to do that is to represent those. So some of those either using an interface potentially where you sense that with a sensor, and then you provide that force as a visual display, or you can use some of these mechanophores, for example, that actually change. If you put too much force, you tune it so that it turns a color. Okay, I just put too much force. The tissue just told me that. Now that isn't realistic, but it's a great training tool because it trains something we can't necessarily see from our naked eye and say, oh, that person's putting too much force on that, anastomosis. The anastomosis model might actually tell us that information.
David Bain, who's part of our department here and does some of our simulation, wants to know how much does it cost to develop a high fidelity open surgical model to get such a product here or wherever else around the country?
I guess I need a little clarification, like a partial task trainer, like a piece of bowel, or like the whole thing for laparotomy.
Maybe for like a laparoscopic procedure, or like a prostate or a kidney or whatever, partial nephrectomy.
I don't know the answer yet. I don't. And I am worried because you see, I mentioned at the very beginning, I showed two companies out there. One of them doesn't offer the system anymore. So their business model didn't work. And it was somebody who knows the business. Lou Oberdorf used to be the CEO of Medi, made a ton of money on simulation. He went into surgical simulation, and all of a sudden now the laparotomy model is gone. That worries me. So, but we have to look at that and learn what was it about his business model that didn't work there. And I do think and Ahmed, I don't know if you were able to talk. I think you can comment on this because you and I talked about on panels on this. I really think that the key is going to be having low cost replaceable tissues within it, but don't have to replace everything in there every single time. So that the users are only replacing or able to just in time use materials that are, again, hybrid. Maybe it's a hydrogel silicone hybrid model, or a virtual hybrid silicone, or virtual hydrogel virtual model, whatever, any combination of those, so that you minimize the cost per training. Because with the systems that I've seen, and including the one again, I don't know for sure if it's gone or not, but I suspect it is, that you have to replace the whole organ or a whole set of organs every single time someone did it. That's not a business model. Who's going to pay for that? So I'm sorry I can't give an exact number because I don't think it exists. And our system we're paying attention to that because we want to make sure that ultimately we're taking one of these hybrid approaches so that we can minimize what we have to replace every time. Otherwise, it's just not going to work financially.
I have a question for you, Rob. So you kind of touched on this a little bit. I was having a conversation with somebody the other day around kind of the changes that we're seeing a lot in boards, how they are evaluating competencies over time. So, continuing medical education, recertification processes are changing. Even the initial, you get the written exam and then the oral exam, and I don't think there's any specialty except for maybe anesthesia that does some element of simulation as part of their exams for board certification. What do you see in front of us as far as being able to integrate this type of simulation training and the value in things like board certification or continuing medical education?
Yeah, I think for certain skill sets, I think we have solutions now. I think in the endo world, I think there's some models that have enough validity evidence to do it. And the process would be to take the ones that have validity evidence for assessment, because we're talking about an assessment, not just training, but an assessment. That's important. If it's valid for training, does not mean it's valid for assessment. So those that have validity evidence for assessment, and take those, and you guys I think are having grand rounds from Cheryl Lee coming up. Am I wrong?
Yes.
Ask her this question. Ask her this question. She's the person to ask. She and I have had talks about this, and I don't want to steal her thunder, but I think you'll get a great answer from her on this one. I'm not part of the boards or the oral boards, but I think there's a movement here to do that. And then you pilot it, obviously, right, and see what kind of data and see if it correlates properly with what the intent is. And I think that we can go there. Again, as long as the cost is reasonable. But the only way we're going to ever get the data we really need is to pilot it. You have to start somewhere and try, and then you're going to start getting the data. If you demand all the data ahead of time, and we're never going to go anywhere. We can get it, but it's not in this particular example where it's a high stakes exam, pass, fail, you're going to do this or you're not going to do this. It's different.
And I like how, oh, go ahead, Marshall.
At UCSF, Hugo Roy's here trying to make an artificial kidney from a physiological perspective. Have you collaborated with people trying to make, artificial organs, for implantable devices and the like?
Yeah, no, we've thought about that. No, we have not collaborated with them because our requirements and needs are different. Ours don't have to be biologically compatible. They don't have to have exact physiology. And right now, I mean, in our world, the cost would be astronomical to do that for training. You make one of these and grow and then destroy it for training. It didn't make a lot of sense, but you're right, collaborating with them, at least in discussing with them, certainly there may be some back and forth there. Ultimately, those fields will converge ultimately.
Because they've worked really hard on trying to have blood clotting and non-clotting, and I can sort of see there would be some synergy with what you're doing, with what Shubo's doing.
I think you're right. I mean, and for non-destructive simulations,
Right.
absolutely.
Yeah.
I think there'd be great collaboration going both ways in that scenario.
Yeah.
But for destructive procedures, that would be, I don't know if they'd let us do that.
I'll have to try to connect the two of you together.
Thank you.
Yeah.
And you've touched on a couple of different facets of training. So, I like that comment around training and testing people are two different things. And so simulation in a training sense is a much different set of needs compared to other examples. And you also pointed out that, especially in today's kind of training environment, certainly within urology, there's been such a shift towards minimally invasive surgery that perhaps the open surgery is kind of where you're going to need simulation in the future. What are you thinking now in terms of how you're partnering with people or strategizing around getting trainers like this or some aspect or modulating them to be more fitting for training environments so you can supplement people's education during their residency?
Yeah, so I think that the Moses platform is a great example of that. And that is, how do we, and I think I'm addressing your question here, I'm not sure, but we can't do this alone. Just one lab trying to take this on, and one lab can do this alone. Something like Moses that allows one person's pancreas model with another person's kidney model and another person's liver model, even though they have their own IP and they have their own development, but the way they're transmitting and receiving information is the same, resolving through Moses with one common physiology engine. It becomes doable. It all of a sudden becomes possible for us to accomplish this. This is a daunting task. Trying to simulate something that man didn't make. We didn't make the human. Trying to simulate something that we don't even 100% understand head to toe yet in all our science that we do in the human body. We're still publishing on trying to understand what we do. To try and simulate that is always a challenge. It's much easier to simulate an airplane because we built it. We know what it does and the forces that are applied to it. That's why, I mean, this is a huge task. That being able to crowdsource that using a platform like Moses, as long as it's being used, and that's why we made it open source and available so that it will get used, I think is our pathway. We have to do something like that. It also makes it more cost effective for any institution to say, we're going to have a Moses compatible system, because now you're working with something that can integrate everyone's work instead of only focusing on one company and all their innovation and success. In a way, it's kind of like the old days of Apple versus Android in some ways.
Right. Well, Rob, I want to thank you for a very inspiring, original, and potential futuristic talk as we move forward on this. And we look forward to hearing more of the progress as you partake in this important project for all of us in surgery. So again, thank you on behalf of the whole department.
Thank you for the honor. It's great to see you.
Okay, take care, Rob. Thank you, everybody. Thank you, Rob.